Healthcare accreditation is often seen as the ultimate benchmark for quality. But the real challenge lies in sustaining quality standards beyond the accreditation process. This session, Beyond Accreditation, the Real Challenges of Healthcare Quality in India, will explore the practical realities of maintaining patient safety, operational excellence, and continuous quality improvement in an evolving healthcare ecosystem. Industry experts, which we have with us today, will discuss the gaps between achieving accreditation and embedding a culture of quality that delivers long term impact. So, I have with me speakers from a renowned organization, Nivara Healthcare Improvement. So, Nivara is a quality improvement consultancy dedicated to making healthcare safer, smarter, and more patient centered. They work closely with healthcare providers to build resilient systems, reduce preventable harm, and elevate standards of care across the ecosystem. And the session is being organized by Voice of Healthcare. Voice of Healthcare is a dynamic platform which is dedicated to making healthcare a priority for all. It brings together diverse stakeholders to foster collaboration, dialogue, and innovation across the healthcare ecosystem. As an impact driven platform, VH amplifies ideas, voices, and policy conversations shaping the future of care. Through expert led discussions and knowledge sharing, PH continues to drive better healthcare access, delivery, and outcomes. Join me in welcoming our speakers for today Dr. Mahtab Singh, Director, Operations and Management, NHI, a public health and quality improvement leader. Welcome, Dr. Mahtab.
Thank you so much.
Dr. Kedar Sawleshwarkar, Director, Neonatal and Pediatric Center of Excellence, Mahaveer Hospital. Welcome, Dr. Kedar.
Thank you, Dr. Manisha.
So, I just want to know that everyone is going for accreditation today. So, is accreditation enough to deliver quality of care, Dr. Mehta?
Yeah, thank you so much, Dr. Manisha. And I think you started with a question which I think is very hot. Should be, I say, should be the very hot questions to discuss today. So I'll start with no doubt I believe in accreditation is one of the most important milestone in healthcare organizations quality journey. But unfortunately, people have taken it as a destination. As of now, whatever I have seen in my experience throughout India and outside. So no doubt it establishes essential standards, strengthens governance and creates accountability. However, if we view accreditation as the finish line, we often witness what many call the certification dip. That means, the enthusiasm of quality gradually fades once we get certified, or the certificate is, displayed on a, wall in our healthcare facility. So, from a system thinking perspective, accreditation provides the structure, but continuous quality improvement, provides the momentum. You know, momentum to the quality improvement journey of a healthcare facility. True excellence is achieved when organizations continuously measure outcomes, learn from data, uh, test the smaller changes, and then adapt. And to this question, I think my simple message is accreditation tells us what good healthcare should look like. But continuous improvement ensures that we keep getting better day after day. So I think this is in response to
Right.
the first question.
Right. I think momentum is definitely important. Once the certification is achieved, we should not stop there because I think meeting the standards and making it acceptable our continuous activity, day-to-day activity. So my next question is for Dr. Kedar. How do we redefine quality in modern era?
Thank you, Dr. Manisha, for the question. And it is a very, very pertinent and important question in today's healthcare era, because we used to define quality as simply compliance to the standards in the accreditation model. Now, in today's environment, quality can no longer be considered as simply this compliance with the standard. Of course, compliance is necessary, which ensures that the evidence-based standards, protocols, and regulations are consistently being followed. And compliance answers to the question that are we doing the things right? But in today's healthcare environment, is another important aspect for delivering quality healthcare is a continuous improvement, which is nothing but systematically improving the clinical outcomes, ensuring patient safety, improving the patient experience, improving the efficiency of healthcare delivery. Now, this is answering the important questions: how can we do even better tomorrow? So, basically, as Dr. Mahtab said, it is a system thinking that brings these two dimensions, the compliance and the continuous improvement, together. Standards, of course, provides you the direction, the benchmark, while quality improvement methodologies like a point of care quality improvement or the PDSA, these are these tools must be considered beyond just the tools, but they are the learning mechanisms. So many government program try to incorporate both these aspects, especially the Lux program, which demonstrated that when accreditation is combined with the structured QI methods, not only we maintain standard, but also we continuously raise them. Because ultimately, the quality is not about achieving compliance once. It is about building the learning organization where everybody is trying to improve every single day. So that is what I believe we should now redefine the quality in the modern era as the organizations which are learning daily and improving daily.
Right, right. I think learning is an inherent part of improving, and I think training, learning, these are the things which should be inculcating in the culture if you want to have a continuous improvement. So, Dr. Mehtab, how can we move from accreditation preparation mode to continuous improvement?
Yeah, again, I think this Manisha, very intelligent question. I think it's not about shifting from accreditation preparation, but like Kedar mentioned, Lakshya program. When I'm one of the person who helped Lakshya to be launched all over India, but that was the first moment when we tried to uh, bring these two things like accreditation as well as the quality improvement together to have sustained improvement. But to my experience, it's very hard to accept this whether it is given results what we thought of in the field. So if I take the question, the biggest mindset shift is to stop preparing for accreditation and start preparing for better patient outcome. Because that should be our real motto, to prepare for better patient outcome. Because all other things is through accreditation are visible, which I said in my answer to my first question. So better patient outcome should be our aim or destination. So this begins by building QI capacity long before an external assessment, because accreditation always happens when you have done something and some external agency come from outside to see whether you have done right or not. So if you achieve that through quality improvement methodology or building your quality skills, that goes on. that carries on. So every department should routinely use simple tools such as point of care quality improvement, PDSA cycles, daily hurdles, and maybe visual dashboards to solve everyday problem. Small improvement projects, uh, I'd say, should be embedded into routine work rather than taking them as a project or a program once in a while. For more sustainable than large effort taken under before an assessment, because assessment usually is reactionary. I'll say that firefighting mode activity rather than a continuous improvement activity. Again, I'll take lecture program example, which demonstrated this beautifully by combining certification with rapid improvement cycles. There was one part of it, the rapid improvement cycles, involving quality circles and frontline engagements. Teams that experience early success begins to see improvement as part of their daily work rather than an additional responsibility. So it should be tasted as smaller successes and then build up so that sustaining of all those goes on. And lastly, I'll say for this question, when improvement becomes everyone's daily habit, accreditation naturally becomes an outcome, not the objective. So accreditation uh, can be a out product of the end point of all other activities. Thank you.
All right. And Dr. Kedar, you have been talking about certain tools which are available. Can you tell us that what kind of tools and how do we integrate such tools in the accreditation system?
Yeah, thank you. So there are many QI tools which are available, methodologies which are available, like point of care quality improvement, model for improvement, Lean, Six Sigma. And with this methodology, there are many tools. So we use 5 eyes, fishbone, process flow diagram, driver diagram. Okay. So all these tools are of course useful, but we need to integrate this methodology into our accreditation system. So I don't see that accreditation and quality improvements to different entities or initiatives. These are nothing but the two sides of the same coin. Okay. So what accreditation identifies is the gap which exists in our healthcare delivery. And that gap has to overcome if we want to improve it. So quality improvements, it provides the scientific methodology to close these gaps. And for that to take place, we need to have the ideal sequence. That is, we need to build first the improvement capabilities in our systems by training the teams in these simple QI methods, encouraging them to test on a smaller scale the PDSA cycles. And then these accreditation standards now become then the milestones to achieve, and that result in the acceleration of the progress. So once we get the accreditation certification, the same improvement methodology which we have trained our people across our organization, we should continue to use it to drive better outcomes beyond those minimum standards. So simply achieving minimum standard is not enough. We need to strive to develop to achieve the healthcare excellence beyond minimum standards. Now, national frameworks like NABH and COS, they have already incorporated the concepts of PDSAs and 5S and all those things, and driver diagrams, etc., all the tools. So what we need is to take the next step and strengthen this framework by embedding the functional QI teams, routine data reviews, the data-driven decisions, and the measurement for improvement as the core accreditation requirement. So to narrate it in simple terms, accreditation, it defines the destination, whereas the quality improvement, it provides the navigation system.
Right. I also believe that getting a certificate, getting the external agency to do the audits is just to find out the gaps. It's not the way forward. If we have to navigate, we have to have certain tools, certain ways which are part of our daily routine, so that quality improvement becomes our habit. So, Dr. Mehtab, why is sustaining, quality improvement after accreditation is particularly challenging in, say, public sector, and how it can be addressed?
Yeah, again, you have picked up a very important topic because somehow private institutes, maybe I can say the corporate hospitals or some standalone facilities, they can manage certification. But in public health facilities, first of all, the issue is to get the certification. But you asked how to maintain that. Again, a very difficult task to handle in public health facilities specifically, because public healthcare operates under unique constraints, in specifically in India, and similar setup of other part of the world, like LMICs, MICs. So, so high those, and the those parameters are we experience on their own every day. High patient volumes. We see. I have experience seeing patients around 250 and 300 per day. When I was a resident in one of the public hospital in Delhi, workforce shortage, frequent staff transfer or transfer to other departments, and then a lot of documentation burden. And I'll say not protected. It's very limited time for quality work with the existing human resources in a public facility. As a result, what happens? Quality often becomes an exercise in compliance rather than continuous. Why I'm saying this, because whenever there is audit for certification, they are bound to follow that compliance process. They were not doing it as a continuous improvement work in the last months or years to prepare for the audit. So I'll say the solution is not more paperwork. It is making improvement easier, like using simple dashboards, daily hurdles, maybe peer learning, collaborative learning from each other, supportive supervision. And I have tried one, I'd say, successful but not so successful because of some other parameters of public health facilities. Hub and spoke mentoring modules have all demonstrated success somewhere in India and other low and middle income countries. But I'll reiterate again, quality should become part of routine clinical work rather than an additional program before going for audits or accreditation. And sustainability improves, and frontline teams experience quality improvement as meaningful, achievable, and rewarding. I think that's something which I have to say about to answer this question.
Right. And I think that that's rightly said, that not only the private sector but the public sector also should, take quality seriously, and should inculcate this in their daily clinical practice, because that is how the patient outcomes will improve, and then the workers or the staff who is working, their safety will definitely improve. So, Dr. Kedar, how can the private sector be incentivized to go beyond a voluntary accreditation towards, say, embedded QI?
Yeah, this is a very pertinent question in the modern healthcare era, that many private hospitals are now opting to accredit their organizations because it enhances their reputation and their market credibility. Also, the insurance sector now demands the NABH accreditation. However, the reputation alone is not enough to sustain the continuous improvement in the organization. In the Western world, they tried pay for performance model, which also failed because the acuity of care provided is different and the different levels of care which are provided by the organization. So you can't compare that. So what we need probably is the strongest incentive is to have a value-based financing. So what is value in healthcare? So value is equal to quality divided by cost. So benefits upon risk. So if we define value in terms of patient's language, so that is what is probably going to drive the incentive in the current or the future era. So what government has also tried in the PMJAY model is they have taken the first important step by offering graded incentives for accredited hospitals. So what we need is the next evolution is to reward the measurable improvements in outcome. So simply the infrastructure or the protocols on paper or the survival is not enough. What we need to document is that we are as an organization are improving. For example, lowering the infections rate, fewer readmissions rate, better patient experience, better clinical outcome. So we need to have a public reporting of quality indicators, and we need to link the empanelment to these demonstrated improvement indicators, and that can create a powerful market incentives. So in the future, hospitals should compete not only on infrastructure but on a measurable value delivered to the patients.
Right. So, first of all, we should have some tools and systems in place, and then definitely, if we have that tool, we have to measure. And for that, we have certain indicators, like you have said, Dr. Kedar, that infection rates should be lesser. And how to do that? That is the way quality improves. Similarly, for other processes as well, we have certain measurable quality indicators, and we should definitely follow those indicators and come up with a root cause analysis if something goes wrong. So, Dr. Mehtab, do current financing and incentive structures reward accreditation status, UI performance, or both?
Uh, I think with due apology to say use this sentence, I'll say that nowadays accreditation is the only motive for most of the facilities, whether it's public or private, because they enables them to have different government schemes, maybe insurance related schemes, and they get a little more incentives when a hospital is NABH, JCI, or maybe NCOR certified. So today, if I say most incentives reward accreditation status more than actual performance. That's my statement. And program such as Kedar mentioned PMJY, Lakshya, and Kayakalp have successfully encouraged organizations to pursue quality certification. However, the global shift is clearly moving towards value-based health. And Kedar has very nicely explained what value-based, healthcare being. So, future financing models should reward both. I mean, structural quality through accreditation and measurable improvements in terms of outcome, which can be patient safety, patient experience, and efficiency. And the healthcare system should reward organization not simply for meeting standards, because that's what is happening right now. If you are meeting, 80 standards out of 100, you are certified. You are eligible to get the set incentives from government or maybe from insurance companies. So they should not be, rewarded for meeting standards, but for continuous improving beyond that, and using all those indicators, Kedar mentioned. Or organization can have their own indicators based on their contextual issues and programs. Thank you.
Right. And I think incentives are there from the government, and as you have, told that insurance, especially, is like PMJ. They are giving more incentive to those hospitals which have NABH accreditation. Similarly, we can have more incentives so that quality work is encouraged. But still, what I feel is that we need to inculcate quality improvement, quality indicators in the system, and that requires a lot of effort. So I want to understand from Dr. Kedar that how can QI approaches help, address the equity gaps that accreditation alone often misses, and so that every hospital, every system which is working in the healthcare should be incentivized to get the quality work done, and to have this accreditation and quality improvement in their system.
Yeah. Yeah, this is an important aspect as far as healthcare quality is concerned, because the more nowadays we are talking about improving the quality, the more we are now identifying those equity gaps that the accreditation is often missing. Because accreditation primarily evaluates whether we have the systems or structures and the processes, whether they are existing in the healthcare facility or not. But it does not always reveal whether each and every patient, irrespective of the caste, creed, religion, socioeconomic status, or geography, benefits equally. So we need to understand this aspect very, very important, because otherwise what will it will result in imbalance and inequity. So what quality improvement does, it is advantageous because it then begins with documenting the data within our systems, the local data. So what it tells us is it helps us identify those disparities across the geographical boundaries, the socioeconomic groups, the gender, or the vulnerable populations, and then we can test the context specific solution based on those gaps, equity gaps. So yes, QI definitely brings the patient and community voice into the improvement process, and thereby resulting in the care being more responsive and more inclusive. So if we consider a system perspective, poor quality in one part of the health system often creates inequity across the entire care pathway. So equity should not be viewed as a separate program. It should be embedded into every quality improvement initiative. So when we define indicators, we need to also incorporate the element of equity into those indicators.
Right. So I think whatever we have been discussing, our one motto is that everything, whatever reaches patients, should be, of good quality, and that is when we'll say that yes, the accessibility, the equity, this has been achieved, and the healthcare system is standardized, and wherever, even if a person is sitting in some remote area, is getting the same kind of quality care as anyone sitting in the city or in metros. So this is, I think, should be the motto, and this can only be achieved not by certification alone or getting the structure made, but having the tools and the indicators of quality in system, so that everyone gets the standard quality care. What my next question is for Dr. Mehtab, that what leaderships and governance shifts are needed to foster intrinsic motivation for QI beyond external accreditation pressure?
Again, question of the hour. And my answer would start with, the people have to think of some sort of, psychological thing inside the, your body as well as, your organization. And the greatest transformation required, I think, is cultural rather than technically. I know everybody is trained so many times. If I take an example, like, do you think staff nurse or a worker working in the labor room is not trained to, give or start the breastfeeding of newborn immediately afterward? Everybody knows. But how it's going on? Even latest data says it's around 44-45% in our country. So the technical change is not required right now. It's the change which is required is cultural, or maybe system change. You have to analyze or take your system as a culprit and work on it. So healthcare organizations need to move from inspection to inspiration, because inspiration brings intrinsic motivation, and inspiration comes from different sides of you in the system where you are working. So and the other thing is from compliance to learning. So we have to shift our focus from compliance to learn continuously and act on that, and keep on filling smaller gaps which we identify, learning through data and our daily work. So I think leaders must create cycle. It has to be start from the leadership, not from below. So first of all, leaders have to change their side. They should keep everybody working in that particular area which they are responsible for are psychologically safe. They are encouraged to have innovation, and every time there is a small win, it is celebrated, and failures are taken as opportunities to improve rather than chances for or occasions for blame or punishment. So when clinicians and nurses are empowered to improve their own system of care and can see better outcomes of their patients, because that brings ownership, because this is my work. But without this, power, they feel like, yeah, I have to do this work. Somehow my boss wants me to, finish this work, I'm finishing this. But when they are given power to, find the innovation, take it as his or her own work, it brings ownership, and that outcomes always better. And this improvement becomes a source of professional pride rather than an external. When they are given chances to use their innovations and work according to their knowledge, according to data, and when empowered with quality improvement tools. So at the end of this, my answer to this question will say culture, more than compliance, determines whether quality improvement becomes sustainable. Thank you.
Right, right. So I think our discussion today is around this, that accreditation and getting the certification is one thing, and building the strategy, building the system, building our daily habits and quality indicators and quality systems so that good healthcare reaches everyone is another thing. So I want to know from Dr. Kedar that what would an integrated national quality strategy look like that optimally, balances accreditation with the scalable QI methods?
Yeah. So what we are witnessing in India, the world, the developed world has already been witnessing this. We have seen that there are isolated quality initiatives, and there are few examples of excellent quality healthcare organizations. But now, in India, we have now the opportunity to move beyond those isolated quality initiatives and create a true learning health system. So, creating a learning health system should be a national strategy, and we need for that five interconnected pillars. So this strategy should rest on these five pillars. First is the aligned governance, which integrates the NABH, NQuas, and the continuous improvement within a single national framework. Now, second is we need the workforce to be capable. So we need to ensure the capability of the workforce with these national frameworks and ensure that every healthcare professionals understand the basic improvement science, the tools and the implementations. The third most important pillar is the digital intelligence. So we need to leverage the concept of the ABDM which we have, where data is available to all healthcare personnel about the individual patients, to generate real-time data. And that data should support learning rather than simply reporting. The next and the fourth important pillar is value-based financing, as we recently discussed. So, based on those value-based indicators, the reward should measure it should reward the measurable improvements along with the accreditation, not simply the accreditation.
Right.
There has to be reward for a continuous improvement. So that is a value-based financing model.
Right.
And finally, the fifth is the culture and equity. Now, here the leadership plays an important role because it is the leadership which empowers the frontline teams and incorporates the patient voices into your healthcare quality. And these leadership principles and the patient voice, they are going to shape the improvement priorities in the coming days. So the future of healthcare quality not only lies in choosing between accreditation and QI, but seamlessly integrating both into one national learning system.
Right. So, while I've heard that what points are there in your mind, Dr. Kedar, that what should be integrated into the strategy at national level, I'm just curious to know that where are we right now? What has already been done, and although this seems so important to me, but I just want to know that where are we?
Yeah. So as I said, we have isolated pockets of brilliance.
Right.
Now that is not enough. So what we need is we need to have a collaborative learning and involvement of all the stakeholders in healthcare, so that we deliver value to each and every patient every time they encounter the healthcare organizations, they access the healthcare organizations. So at present, we are heavily reliant upon the accreditation model, which of course is the quality 1.0. What we need is a quality 2.0 where we should have systems in place, we should have processes, we should have the improvement methodology where we train our healthcare people, in empower them, improve their capabilities, increase the capacity and capability building of these into the QI tools. And the third most important is co-production, where we involve patients into the improvement initiatives. So patients' voices, patients' active participation must be encouraged, must be there. So that is what is quality 3.0. So now we need to move from quality 1 to 2 to quality 3. So at present, in India, we are on quality 1.0, where we try to meet minimum standards. Okay. Some of the organizations have started moving towards quality 2.0, where they're using quality improvement methodology to good effect and improving their outcomes. So what we need is now we need to improve upon that and add an element of co-production to sustain those improvements and further improve.
Right, right. So my last question is for Dr. Mehtab. I just want to know that since we have taken an initiative, how do you think can NHI and VOH, contribute in creating a culture of continuous quality improvement across public and private healthcare sectors?
Thank you, Dr. Manisha again. And this is what I really wanted to know. Our audiences are maybe other people who are going to, uh, see or go through our recorded version later. Like, NHI and VOH are now very uniquely positioned to become national catalysts for quality transformation. I have no doubt because, since last, I think, when we started in 2013, it was a, USAID funded project, assist applying sciences to strengthen and improve system. That was the time when quality improvement really, introduced to Indian health system. Before that, some individual facilities were doing it, but in public sector, it was a broad then. So then a couple of organizations has come up that include our NHI and DOJ. So our basically, main area of work is to, promote accreditation along with the capacity building for, continuous quality improvement through training, uh, national, collaborative networks, mentoring across, institutions, promote implementation research, recognize innovation, and, advocate policies that integrate accreditation with continuous improvement. And most importantly, they can help, change the national narrative. Why I'm saying this? Because, from inspection to learning will come when we, combine both these things. Till now, it's all, inspection. But when, quality improvement, accreditations come together, or when we include all the, national collaboratives, quality improvement, capacity building, uh, supportive supervision, on-site and, remote mentoring. So this will bring a shift or change. And NHI and VOH can do it, very well because we have very experienced, resources with us. Many of us, have more than 15 years of working in quality, uh, just accreditation system. I have myself have been, associated with NQuas since its inception, since I think almost 10 years with NABH, but because of this now I have to, leave that NABH accreditation part from my work. So this, improvement is from compliance to improvement is very important. And again, this will, because I have mentioned earlier also, this will bring individual excellence to system-wide transformation. When our system is excellent, the outcomes would be automatically excellent. So at the end, I think I'll read these two lines. If we truly want to improve healthcare quality, we must build not just accredited hospital, but learning health systems. We should, take our hospital as a system, which includes everything: infrastructure, human resource, technology, quality improvement trainings, and all. And that is, I think, the journey beyond accreditation. Thank you so much.
Yeah. So I'll add a few things over here, Dr. Manisha. So what is our role is to sensitize, train, handhold the healthcare professionals and the organizations in understanding the healthcare quality, that is the whole system quality. So a whole system approach towards quality. Unfortunately, the planning for quality is non-existent in our country at this moment. So we have the mechanisms for accreditation or the quality assurance. We have the tools for quality improvement, but we are not planning for quality. And for that to occur, we need to have quality as an organizational strategy at organization level, but also quality as a national strategy at the government level. So it has to create a golden thread, you know, with the quality as a national strategy. So the goals for quality as a nation, those which then will be followed by the organizational goals based on the work they are carrying out, the indicators they have with them. So they should align with the national priorities, and in the departments, individual department inside an organization, the quality improvement initiative should align with those strategies or the goals. So if we do that, then we can ensure the leadership support, the infrastructural support, and ensure the quality improvement is taking place on a day-to-day sustainable way.
Right, right. I think we have taken an initiative by having the discussion around this, that quality 1O should move to quality 2, and then the 3O, wherein patients should also be part of the whole system. And so that we should have proper feedbacks, and we should have the quality indicators and the system in place, so that it becomes our daily habit. And not only the goal should be to achieve the certification, but to have the measurable outcomes and to improve those outcomes if they are not in place. So, with that note, I close this virtual session, and I thank my speakers for joining us today.
Thank you very much, Dr. Manisha. Thank you for a
Manisha,
wonderful and enlightening session.
are there any questions from audiences? No questions.